A very good evening to all of you present on today's session. I am Nishita from ClearNet. Welcome everyone on Indian Medical Association Junior Doctors Network, Tamil Nadu presents Gastric Outlet Obstruction, Surgical Interventions, Complication and its Management. ClearNet is proud to be associated as a digital partner. Now I am going to play a very short ClearNet's video. I would like to request all of you, please have a look. Thank you so much everyone for your patience watching. ClearNet is India's largest live digital CME and doctors generated medical content platform. Now I would like to hand over the session to Mr. Praveen Ace, who is pre-final MBBS, Madras Medical College, Chennai State President, SNO, Tamil Nadu. Mr. Praveen, over to you. Please proceed.
Thanks for the introduction, Nishita. So, good evening and warm welcome to all. I am Praveen, doing my pre-final MBBS from Madras Medical College, Chennai, State President of SNO Tamil Nadu. I feel really elated to see medical students and doctors have joined this webinar from across the length and breadth of this nation. IIMS JDN has been doing plethora of webinars on various topics with the objective of disseminating knowledge and keeping the medical community informed and updated. IIMS JDN, in collaboration with Student Network Organization Tamil Nadu, presents the topic Gastric Outlet Obstruction, its surgical intervention, complications, and management. The pattern of our webinar is Dr. Abulasan Sir, a senior pediatric surgeon from Erode. Sir is the chairperson of IIMS JDN Tamil Nadu and also IIMS Tamil Nadu State President Elect 2024. And we have with us Dr. Venkatesh Karthikeyan Sir, who is the Community and Family Medicine PG from AIIMS Patna. He is also General Secretary of IIMS JDN Tamil Nadu. I feel honored to introduce the speaker for today's session, Dr. Rajamahendran Sir, who has done his MBBS, MS, FRCS from Edinburgh, FMAS, MCH in Surgical Gastroenterology. Sir is currently working in Government Villupuram Medical College and Hospital, Villupuram. Founder, Dr. Rajamahendran Sir is the director and founder of RRL Next PG Coaching Institute and an educator in an academy. He is a pioneer to start MCH, Surgical Gastroenterology Medical Entrance Coaching in India. Sir has authored 10 medical books and co-authored many more in surgery, pediatrics, OG, and several other entrance exam books. He has also published several international journals, including embryonal rhabdomyosarcoma, palliative resection and carcinoma, etc. Sir is also a great fitness enthusiast and has a tremendous following in social media platforms such as YouTube, Instagram, and Facebook. So with this, we shall move to the session. You can take over the session, sir.
Thank you so much, Praveen. Thank you, Dr. Venkatesh. Thank you, Abul Ghasem sir, for introducing me and inviting me for the session. Shall we start the session?
Yeah, sir. Yeah, sir. We can start the session.
Okay.
Excuse me, sir. Before that, I would like to request Dr. Abul Ghasem sir to give the welcome address.
Yes, it's okay anyway. Good evening, Venkatesh and Praveen and Dr. Rajamahendran. I'm very happy indeed to participate in this in a kind of series of CME programs organized by Venkatesh and Praveen and in JDN platform. JDN has been concentrating on a few of the issues of junior doctors today. The first and foremost thing is the academic growth and skill development, and also help people to crack competitive exams like NEET. So we have been holding this, conducting this series of webinars, and there's one among the seminars today's talk by Dr. Rajamahendran. And in this context, I also like to inform everybody, all the delegates, that we are IIMS JDN of Tamil Nadu State Branch is organizing a World Young Doctors Day celebration on coming June 24th, that it falls on Friday, from 8 a.m. to 5 p.m. Wonderful workshop and preliminary sessions are lined up. It will be a real treat for all the young doctors. And we have been, kind of motivating a board, kind of young doctors welfare board to help our young doctors to get their objectives of academic growth, job opportunities, leadership development, and so on. So this meeting is one of the developments in that direction. And I wholeheartedly invite on behalf of the organizing team, every one of you to come and attend the function. Whoever is very close by, it will be very easy to reach Chennai and attend. And yeah, and I wish all the delegates of today's seminar to have a very good time, very good day with Dr. Rajamahendran. Thank you very much for the opportunity. Over to you, Dr. Venkatesh.
Thank you so much, sir. I know how busy you are in organizing this 24th event. I would also like to quote that Health Minister and many senior members, senior politicians are also coming for our event. I hope it will be a great event, and it will be of great value addition to students if they are attending. So without further delay, I would like to just quote two things about Rajamahendran, sir. First thing is that many of you might be familiar with sir as an author of surgery books. People might be reading his surgery books, but even before reading his surgery books, I'm one of the students who read his OG book. So I got benefited by his OG notes, OG practical notes. I only read that for my OG practicals. So like that, sir is writing many books and he's influencing a lot of people. Even just now, I'm sitting outside my library, and even while walking out of the library, I could see people watching sir's recorded videos. So that is the reach and impact sir is giving to the doctors community. And I'm very much sure that sir is going to be he's going to influence the history of medicine and surgery in India. So we are so glad that such a great person, such a legend is with us today, and he has spared his precious time to educate all of us now. So thank you so much, sir. Without any delay, I'd like to request you to continue with the session. Thank you, sir.
Thank you, Venkatesh. Thank you so much for your introduction. Thank you all. Shall I start the session now?
Yes,
Yes, please. Sir.
I'm sharing my screen. Yes. It's a very interesting topic and a very favorite topic for PG examiners as well as for the clinical examiners. So gastric outlet obstruction. So basically you should know what is gastric outlet obstruction. So gastric outlet obstruction, it is different from small bowel obstruction. You should know the difference. Small bowel obstruction is different. Gastric outlet obstruction is different. What do you mean by gastric outlet obstruction? Okay. If there is an obstruction in the GI pathway up to DJ flexure, okay, this is DJ flexure. If you have an obstruction up to DJ flexure, we never call it as small bowel obstruction. Okay, for example, if there is an obstruction in the duodenum or obstruction in the pylorus or in the first part duodenum or somewhere in the stomach, we don't call it as small bowel obstruction. Any obstruction of the bowel distal to the DJ flexure, like in jejunum or ileum or in the colon. If you get an obstruction in any of these distant places, like in the jejunum or ileum or colon, we call it as intestinal obstruction. So no confusion in this. You should have a clear idea of what is GOO. So gastric outlet obstruction is obstruction in the area up to DJ flexure. So please remember, up to esophagus, if there is an obstruction, we don't call it as GOO. Obstruction of the esophagus is called as dysphagia. We call them only as a dysphagia or a esophageal obstruction. But then what is GOO? GOO is obstruction in the stomach or obstruction in the duodenum up to DJ flexure. So this is known as GOO. So though other obstructions are not, I'm not going to discuss today, but you should have a clear idea. If it is an intestinal obstruction, patient will have 4 cardinal features. Four cardinal features are seen if the patient is having, for example, a small bowel obstruction is there. They have 4 cardinal features. Like a first important feature is colicky pain. Please don't forget, they will have a severe colicky pain. The foot is not able to move, so they have a colicky pain. Number 1. Second, followed by bilious vomiting. Very important, bilious vomiting. Number 3, they will have abdominal distension. The distension will be diffuse. It will not be a localized distension. It will be an abdominal distension. There will be severe distension of the entire abdomen. And number 4, they will have obstipation. Obstipation means not passing motion as well as flatus. There will be obstipation, abdominal distension, bilious vomiting, and colicky pain. So there are totally 4 features in a small bowel obstruction. Please remember, a small bowel obstruction can never be kept as a clinical case for your exam. So this is just for theory you are reading here, small bowel obstruction. So what will be kept for your exam is going to be a case of GOO. So now tell me, what are the features of gastric outlet obstruction? So this is very important thing. The patients will first of all have VGP, the three classical features of, there are 4 features I told you for small bowel obstruction, but for obstruction of the upper GI like stomach and duodenum, the features are: number 1, visible gastric peristalsis. Number 2, we have ball rolling movements. Patient will have ball rolling movements. That on inspection we see a feature of VGP. So the ball rolling movement is the history. The patient will come to you. They will tell, I'm feeling something rolling on the upper part of the abdomen. And on inspection, you can see a visible gastric peristalsis. And number 3, there will be vomiting. There will be definitely a vomiting will be present, and it will be undigested food. It will not be a immediate food which they consumed. It will be usually an undigested food. Even the food taken yesterday or even day before yesterday will be coming out now as vomiting. So these are the classical findings we are going to discuss in gastric outlet obstruction. So before going to the further discussion, you should know what are the causes of GOO. I am going to now go into the causes of gastric outlet obstruction in detail. So this is a DJ flexure. There is no more beyond. We will call it as GOO. Only obstruction in this location, we call it as gastric outlet obstruction. Let me divide the causes into adult causes and pediatric causes. Okay, adult and pediatric causes. So pediatric cases are not going to be kept for your exam again. You are going to only get an adult case in your exam. So what are the common causes of GOO in adults? The most common cause. Can somebody tell me what is the most common cause? The most common cause is cancer in the distal stomach. Please remember, CA stomach. It is not a proximal cancer stomach. It is a distal gastric cancer which can cause GOO. So GOO is a finding of distal gastric cancer. Please remember, a proximal cancer like this here will not cause a GOO. It will only cause a dysphagia, which will not be considered under GOO. So this will cause, but this will not cause. So distal gastric cancer will cause GOO, number 1. So number 2, which is one of the common causes some years back, some 15 years back, if a patient with GOO was coming to the clinic before 2000s, we'll immediately think it is a case of chronic duodenal ulcer with cicatrization. Please remember, with cicatrization. So if there is a duodenal ulcer here, it will heal. As the duodenal ulcer is getting healed, it will go for a narrowing known as chronic duodenal ulcer with cicatrization. So my handwriting is coming a little bad in this Zoom because the screen sharing has a little problem. Therefore, it will be not so much clear, but I will draw the diagrams very clearly. Don't worry. So CA stomach is the most common cause. Chronic duodenal ulcer with cicatrization is another cause which was seen olden days. So what are the other causes in adults? So DO with obstruction. Very important, another cause is any problem in the pancreas. For example, if there is a cancer in the head of pancreas, if there is a cancer in the head of pancreas, it can cause compression. CA, head of pancreas. Number 4, you should not forget, this is a very common cause again. There is a chronic pancreatitis. Patients with a chronic pancreatitis. Chronic pancreatitis can cause GOO. Number 4, the patients with a pseudocyst. Pseudocyst in pancreas can cause GOO. For example, this is a pseudocyst which will compress the duodenum and will cause GOO. So I'm telling you the common causes which we see in regular practice: distal gastric cancer, chronic duodenal ulcer with cicatrization, CA head of pancreas, chronic pancreatitis case, pseudocyst in pancreas. So any other adult cause you know? Yes, there are so many other causes. One of the important causes here. So this is aorta. This is superior mesenteric artery crossing at the level of third part of duodenum. So please remember, superior mesenteric artery crossing at the third part of duodenum can be causing a compression of the third part of duodenum known as Wilkes disease. So Wilkes disease, these are the commonly seen causes in adults. So please remember, adults: cancer stomach, duodenal ulcer, cancer head of pancreas, chronic pancreatitis, pseudocyst in the pancreas, and Wilkie's disease. So these are the common causes in adults. In adults, there are two interesting more causes. They are known as trichobazar and phytobazar. Trichobazar means psychiatric patient plucking their hair and they are eating. So hair will go and obstruct the stomach and duodenum is known as trichobazar. Then phytobazar, which is not only seen in psychiatric patients, it is also seen in diabetes mellitus with gastroparesis. Diabetes mellitus with the gastroparesis patients, we get a phytobazar. So diabetes mellitus with the gastroparesis patients will get phytobazar. So diabetes mellitus patient, the stomach will not be properly moving. So whatever vegetables they are going to eat will get stagnated in the stomach and it will cause an obstruction known as phytobazar. So for your exam, clinical exam, what are the cases that can be kept for your exam? Number one, cancer stomach will be commonly kept. Chronic duodenal ulcer may be kept. Cancer head of pancreas may be kept. Pseudocyst may be kept. And these other cases are very rare to get in practice. So don't worry, you should be thorough with these 4 cases of GOO in adults. So though there is no pediatric exam case for you in final year or in even a postgraduate period time, usually they don't give pediatric cases. I will tell you what are the pediatric causes. So most common cause you should know here is congenital hypertrophic pyloric stenosis. So CHPS, congenital hypertrophic pyloric stenosis is the most common cause. Then there are duodenal atresia, jejunal atresia, annular pancreas. So please remember congenital hypertrophic pyloric stenosis, duodenal atresia, and as I told you, I will not consider jejunal atresia in GOO. It is distal to the DJ flexure. So I will not consider as GOO. It will be considered under small bowel obstruction. So then annular pancreas. So what are the causes in pediatric cases you get means it is congenital hypertrophic pyloric stenosis, duodenal atresia, and annular pancreas are the common cases in pediatric condition. One simple history will differentiate CHPS from other causes of pediatric. What is it? That is, in congenital hypertrophic pyloric stenosis, obstruction is here. So therefore, they have non-bilious vomiting. Please remember, they have non-bilious vomiting. These two guys will have bilious vomiting. So otherwise, pediatric cases are not kept in exam. Just for a basic MCQ in a PG entrance exams, what is the difference between CHPS and duodenal atresia means? In duodenal atresia and annular pancreas, we have bilious vomiting. In congenital hypertrophic pyloric stenosis, there is non-bilious vomiting seen. So these are the important things you should not forget in gastric outlet obstruction causes. Okay. So now let us go on to the clinical examination, clinical history taking. Actually, I don't know whether this case was discussed as a theory case or a clinical case, but I'm going to discuss more as a clinical case discussion only. So when a case of GOO is kept in the exam, the two commonly kept exam cases are going to be only a cancer stomach. In exam for final MBBS student, you'll get only a cancer stomach in the distal part causing GOO will be kept in the exam, or number 2, a peptic ulcer disease with a chronic duodenal ulcer cicatrization will be kept in your exam. So all your history will be focusing on these two cases only. CA stomach or chronic duodenal ulcer with cicatrization will be your focus. So every question you are going to ask now for these two cases is going to be a cancer stomach and for a duodenal ulcer. Let us assume this is Mr. Ramu, 60 years male, coming to you with a GOO. And this is Mr. Somu. He is a 30 years male. Okay, 30 years male, Mr. Somu coming to you with a GOO. So we are going to differentiate the clinical features of Mr. Ramu and Somu. So please remember, Ramu is going to have a cancer stomach. Somu is going to have a chronic peptic ulcer disease with cicatrization. Let us start the history for these two guys. So the first important thing to say, Ramu may have cancer is his age group is old age. So chronic duodenal ulcer is common in young age. Is common in young age. So now you have to ask them what they both will have the same presentation. Please remember, clinical feature of these two cases are, clinical feature of the both the cases will be, they will come to you with a vomiting. They come to you with a vomiting of undigested food particles. Undigested food particles consumed even 3-4 days back, number 1. They come to you with a history of ball rolling movement. Ball rolling movement. They come to you with a history of loss of weight. Loss of weight is present. So these are the three important history they will come to you. So loss of weight will be there, ball rolling movement in the upper abdomen will be there, vomiting of undigested food particles will be there. These are the classical features of gastric outlet obstruction in Ramu and Somu. They both will come to you with the same feature. How to differentiate whether it's a cancer or a peptic ulcer is now starting from the history. Okay, it's going to start from history. Okay, number one. Who will have a short-term history? Who will have a long-term duration? So the duration is very important thing now. So you should understand cancer will have a less than 6 months duration of vomiting and other things. Whereas peptic ulcer will have history of years together. So it may be, they may be having a vomiting on and off for more than 1 year, 2 years, or having a similar episode before. Like that, long history is for duodenal ulcer. So long history. Whereas cancer will have short history of less than 6 months. The most important thing which is going to help you to know whether it is a benign or malignancy is going to be asking an important history known as pain, associated pain. So can you tell me what is the associated pain in cancer stomach? Yes, they may be painless. Painless, very interesting thing. Cancer may be painless for long period, but they may have pain once it infiltrates the pancreas. Please remember, once it infiltrates the pancreas, posteriorly, it can have pain. And this pain will be unrelated to the food. Please remember, unrelated to food. Pain in cancer, if it is going to happen, it is an advanced disease and it is unrelated to food. And if there is a back pain, please remember the patient might have had cancer infiltrating into the pancreas as a cause of back pain. So all these are findings which will lead you to cancer stomach. And the pain in case of duodenal ulcer is typical. They will have long history of pain, pain relieved by eating. Very interesting point. Pain relieved by eating. So you know very well, a duodenal ulcer patients, the pain will be relieved by eating, and a gastric ulcer patient, pain increased by eating. And not going to the basics of peptic ulcer disease, but pain relieved by eating. And these guys keep on eating all the time to reduce the pain. Therefore, a duodenal ulcer patient would have been obese initially. Initially, a duodenal ulcer patient will be obese. They are common in a young age and they will be obese because pain relieved by eating. They keep on eating all the time. So eating decreases the pain. And please remember, therefore, they might have had a weight gain initially. And it is periodical pain, periodicity. A classical finding of duodenal ulcer, periodicity. What is this periodicity? Periodicity means they have more of pain in the autumn season and in winter season, because water is an alkaline medium. In summer, we keep on drinking water and the duodenal ulcer is little silent. Whereas in the winter, we don't drink much water. Therefore, we have more of pain. So periodicity is more common in autumn of winter season, and in the cold seasons, we have more of pain. And that is why you would have seen when your house agency, you would have seen more and more of duodenal ulcer perforation patients are common in the winter season. Summer season will get less of perforation cases. So pain, and the pain itself will come to make you a clarity whether it is a peptic ulcer or a cancer. Very important thing. Okay. And loss of appetite plus weight is more in favor of cancer. Loss of appetite and weight is more in favor of cancer. They have cachexia. The patient will look very cachectic. It's classical finding of cancer stomach. Okay, it's a finding of cancer stomach. So these are the important histories you should know in the history taking. Okay, in the history taking, you should ask all these findings, and you have to now. You are coming to a conclusion from the history. You think it can be a cancer or it can be peptic ulcer disease, and you are going to examine clinical examination of abdomen. So I am now going to examine the abdomen, and you have to elaborate in detail about the vomiting in the history. So vomiting should be elaborated in detail before going to clinical examination, which I am not going, because if I take everything in detail, I could not cover in 2 hours. So vomiting in GOO, what are the questions you should ask? So the vomiting is bilious or non-bilious? First question, it is non-bilious because obstruction is proximal to the ampulla. And what is it containing? It containing foul-smelling, undigested food particles. Undigested food particles are seen for a long, long period. They have vomiting of undigested food particles. So which is more common with peptic ulcer? Undigested food particles is more common with chronic duodenal ulcer than cancer stomach. In cancer stomach, the undigested food particles will be less. Because of the cancer, the stomach could have already become smaller. Whereas in a peptic ulcer, the stomach becomes bigger and occupies and contains all the undigested food particles for a long time. So vomiting is non-bilious, undigested food particles will be there, and it is projectile, and you should ask for history of association with blood known as hematemesis. So history of hematemesis you should ask. So who will have more of hematemesis means, please remember, it is chronic duodenal ulcer cases might have had more of hematemesis. Cancer stomach hematemesis is less common. In a cancer stomach, they may have melena. The bleeding may present as melena, but not as hematemesis. Hematemesis is very common with the old duodenal ulcers. So duodenal ulcer might be associated with hematemesis. Cancer stomach may be associated with melena. You should ask all the other associated histories of related to cancer and related to peptic ulcer. From history taking itself, you can confirm, okay, this is a cancer or this is a peptic ulcer at the end of history taking. Okay, so this is basic thing you should not forget in history taking. Let me go on to the clinical examination of the abdomen in cancer stomach and then peptic ulcer. The three common findings you will see are inspection, you see VGP. Please remember, there are three findings you have to see. Inspection, there will be VGP. The peristalsis starts from left side and moves to the right side. That is known as VGP, peristalsis of stomach from left to right. So there is another peristalsis in small bowel obstruction known as VIP. VIP is left to right or right to left. It can be in any direction. But our case will have VGP, visible gastric peristalsis. Very important point. And in inspection, you can see visible gastric peristalsis and a fullness in the epigastric region. And you sometimes, if it is a cancer, you will see a mass also in the epigastric region. So VGP you should look for. Then you should look for succussion splash. So succussion splash should be noted. Please remember, succussion splash should be noted only after giving more than 2 hours of solid food. It should not be done within 2 hours of solid food because the solid food itself can cause some succussion splash sound. It should be done 2 hours after solid food. Okay, so and liquid food should be avoided before doing this test. Liquids must be avoided before doing this test. So therefore, it's an interesting question in the exam. Which one will you do first? Will you look for VGP first or succussion splash first? Means, please remember, I should look for succussion splash is done first. So you have to do a succussion splash test. Means we make the patient lie down and shake his abdomen like this. When you shake his abdomen, even you might have had the succussion splash in your stomach after drinking 1 liter of water, you can hear the succussion splash sound. So that sound can be heard for patient who is on not any diet for more than 2 hours and not taken any liquids. So VGP will be present only on taking water. So therefore, when you are going to test for VGP, we will be giving water, which should be done only after doing a succussion splash test. Okay, so succussion splash is done first. Then you give water and look for VGP. And now you should look for the distension of the stomach should be found out. By what method? Distension of stomach. So distension of stomach is identified by keeping a bell of stethoscope near the umbilicus region. You keep the bell of stethoscope like this and you start scraping with the key like this from inside to outside. Inside to outside, you start scraping like this. On scrapping, you can auscultate. There is a change in resonance from one place to another place. The distended stomach can be marked fully like this. So the stomach will come even up to the hypochondrium, above the bladder level, it will come this much. Stomach is distended. This test is known as auscultoscraping. The examiner will be waiting for you to tell auscultoscraping test. So 3 important tests: VGP, succussion splash, auscultoscraping are the 3 important tests you must do. You must do these 3 important tests: VGP, succussion splash, auscultoscraping in any case of GOO. In any case of GOO, you must do these 3 tests: VGP, succussion splash, and auscultoscraping. So now we are going to these 3 are common. It is seen in both cancer stomach or peptic ulcer. You get these 3 features common. How to differentiate it is a cancer stomach or a peptic ulcer disease? By examination, I am going to tell you what are the findings which will favor more of cancer stomach findings. Cancer stomach findings, number one important finding is if there is a mass with GOO, it is cancer. It's a very basic MBBS, second MBBS level question. A GOO with a mass is more of cancer. A chronic duodenal ulcer will have GOO with no mass. Very basic question. So mass with the GOO is cancer stomach. A GOO with no mass is duodenal ulcer. And in cancer stomach patients, you should know the features. The features of these patients are STOMACH. You have to look for these 7 findings in history taking, and you should look for 5 MCQs for your exams will be asked in clinical examination. So the questions are, in stomach cancer, the cancer can be a silent cancer, or it can be a tumor. The patient can come to you, I'm having a mass tumor. Or the patient can come to you as GOO. Patient can come to you as melena. Patient can come to you with a slow bleeding causing anemia. Patient can come to you with a cachexia. Patient can rarely come to you with a hematemesis. So these are the features of cancer stomach. Stomach is a mnemonic for cancer stomach features. Silent, tumor, obstruction, melena, anemia, cachexia, and hematemesis. So these are the classical features of stomach cancer. And what are the 5 MCQs you have to examine clinically? Are number 1, Sister Mary Joseph nodule. I'm telling you, if you are a final year student and if you are going to miss a Sister Mary Joseph nodule in your final year exam during the examination time, your pass is at risk. Okay, please remember, Sister Mary Joseph nodule is a very basic thing. You have to find out there is an umbilical deposit. Many students are failed not for answering very high-tech questions. They are failed only for missing a basic finding, which is very commonly seen. I'll tell you which place you will fail in a cancer stomach with the GOO. If a patient has a Sister Mary Joseph, you missed, you might fail. Number 2, if a patient is having a left supraclavicular node, what is the name of this node? It is known as Virchow's node, also known as, the sign is known as Treissier's sign. If you are going to miss this, your life is in stake at this point of time again. So Treissier's sign should not be missed. So Treissier's sign, umbilicus deposit are 2 important findings you should never miss. If you are going to miss, you are at risk of passing. So other things, if you are a MS postgraduate, the following findings, if you don't tell in your exam, you are at risk. They are Bloomer's shelf. So these are for MS PGs. You have to examine for Bloomer's shelf is nothing but rectal deposit. The deposit in the pouch of Dowler's or rectovesical pouch, you have a deposit of cancer. Krukenberg's tumor, if she is a female, okay, if a patient is a Krukenberg's tumor of bilateral ovarian enlargement, bilateral ovarian deposit is known as Krukenberg's tumor, you should not miss it. So it is also a chance of a malignancy, so which is having a METS. And don't ever forget to see for Sister Mary Joseph nodule, left supraclavicular node, Bloomer's shelf, Krukenberg tumor, and Irish node. What is Irish node? Irish node is left axilla node. Left axilla node. And what are the other findings apart from these findings on clinical examination? What are the other findings which may lead you to a cancer? Number 1, ascites. If a GOO patient is having ascites, you should think of cancer stomach. If a GOO patient having liver secondaries, you should think of cancer stomach. So secondaries in the liver, ascites, are classical features to say it is more in favorable of cancer and less favorable of chronic duodenal ulcer. In simple, I will tell you, for exams, you will never get chronic duodenal ulcer cicatrization. No such patients are seen in the practice. In my practice, every year I see only 2-3 cases of duodenal ulcer cicatrization, but I see hundreds of cancer stomach with GOO. So definitely you will get cancer stomach with GOO, but in exam, you will never get a chronic duodenal ulcer with GOO. So be thorough with the cancer stomach causing GOO. Okay. So these are the clinical findings are being done now. And now let us come to a final diagnosis. The diagnosis is made as cancer stomach. Cancer stomach. As a final year student, you will be presenting this is a case of cancer stomach with gastric outlet obstruction. This is the final diagnosis you will tell now. So as if I'm sitting an examiner, I will start asking you the leading questions from the diagnosis. The first question I will ask you is, if you are expecting this is a cancer stomach, doctor, where do you think the cancer will be? The question will be, where do you think the cancer will be? So I feel the cancer is more chances of cancer is seen in pylorus or in the antrum. Please remember, sir, I feel this is a case of cancer in the pylorus or in the antrum. First thing you should tell like this. So I feel the cancer can be in the pylorus or antrum. Immediately the examiner asks, can it be a cancer in the proximal stomach? So you should tell a proximal gastric cancer if it is present, sir. It will not cause GOO. It will only cause dysphagia. Like that you should tell. So the proximal cancers will cause more of dysphagia. It is a distal gastric cancers which will cause more of CS stomach with GOO. So my diagnosis, therefore, more the location of obstruction is at pylorus and antrum is my suspicion. Immediately the examiner will ask you, can you tell me a case of obstruction with no VGP, a cancer with no VGP? There is no VGP seen, but patient is having vomiting. I am telling it is cancer only. What is the diagnosis? I am telling it's a cancer. There is no VGP seen. You are seeing there is no VGP. There is no vomiting. But examination, there is a mass present in the epigastric region. I am telling this is a cancer. What is your diagnosis? So this is an interesting type of rare type of cancer which is seen in E-cadherin mutation known as Lawrence classification of gastric cancer, diffuse gastric cancer, the type causing Linitis plastica. So Linitis plastica is a cancer in which the tumor is infiltrating the entire stomach wall like this. The tumor is infiltrating the entire stomach wall like this. And therefore, the stomach has become like a small leather bag, like a small pouch. So whatever you eat, there is no place in the stomach. They will vomit immediately. They will vomit immediately. There is no place to keep in the stomach. Therefore, they have yearly satiety features. So another cause of gastric outlet obstruction can be a diffuse gastric cancer caused by Linitis plastica, one of the high-yield MCQs for your exam. So Linitis plastica, the common feature is yearly satiety because stomach is an elastic organ. You can put 2 unlimited biryani in the stomach. That much stomach can extend. So you can eat enormously. It will not going to vomit. So you can even eat a empty number of food. You can chicken, everything you can eat. The stomach will expand because it is an elastic organ. That elasticity is lost in diffuse gastric cancer. Please remember that elasticity is lost in diffuse gastric cancer. You should not forget this condition of the diffuse gastric cancer causing Linitis plastica. So the moment you present the case as cancer stomach with GOO, the examiner will ask all these questions. And the next question the examiner will ask you is, why not this case a case of chronic duodenal ulcer with GOO? Why not it is a chronic duodenal ulcer with GOO? You should justify, sir, I feel this cannot be a chronic duodenal ulcer with GOO because the patient is very young case, very young age. So when you tell a patient is very young age, the examiner may ask you, will cancer stomach not occur in young age, doctor? What should you tell? So the cancer stomach in case of Lawrence classification, diffuse gastric cancer can happen in young age. It can happen in young females. It is associated with E-cadherin mutation. Yes, it can happen in such cases. Young females can get cancer. But interesting point is these cases, the cancer is more common in the proximal stomach. Proximal stomach, and the chances of distal gastric cancer causing typical GOO is very rare with the diffuse gastric cancer happening in young females due to E-cadherin mutation. The cancer is more in proximal stomach. Please never ever forget this point. So therefore, first thing you should tell, I am expecting this case is a duodenal ulcer because he is an young age. Number 2, he is having the typical symptoms of duodenal ulcer. Typical duodenal ulcer symptoms he is having. You should tell only that. You should tell, sir, he is having a typical, he is having no typical duodenal ulcer symptoms. Typical duodenal ulcer symptoms are absent. So absent, what then? Immediately you should lead the examiner to put your questions. You should make the examiner to ask you. So typical duodenal ulcer means what do you feel that is duodenal ulcer symptoms? You should tell, sir, pain relieved on eating, pain relieved on eating and pain more on empty stomach, and the patient keeps on eating all the time, periodicity of pain, patient is obese, all these are features of typical duodenal ulcer symptoms. Okay, and you should tell on examination, I could see a mass. Mass is absent in duodenal ulcer. Mass will be definitely present in most of the cancers. You can palpate the mass, firm mass moving with the respiration, you can always find it. So mass is absent, therefore I don't think it is a case of duodenal ulcer with GOO. I feel it is a case of cancer stomach with GOO. I'm telling you, at this point of time, you are already passed in your exam. I'm telling you, at this point of time, you have completed the history presentation, everything. You are already passed in your exam. Hereafter, the questions are going to make you get more and more marks. That's all. So the investigations now are going to be done. So the moment you tell, sir, I'm going, how will you confirm your diagnosis, doctor? You should tell, I'm going to investigate the patient further. So what will you do further? The question will stop at this point. So the examiner will ask you a question on, once you present it, the examiner will ask you, what are you going to do for this patient now? So the moment the examiner is telling this point, what are you going to do for this patient now? This is a very important and a catch question. And if you're going to tell the correct answer for this question, you're going to crack the exam with the highest score, because the next important thing I will do in this patient is what? The moment I have confirmed a GOO case, the next important thing I should do is I should correct the fluid and electrolyte imbalance. You should tell this. I am least bothered whether the patient is a cancer or a duodenal ulcer at this point of time. I am not worried about whether it is a cancer or duodenal ulcer, because my aim is the patient is not eating for the past 1 or 2 months, vomiting all the time. So I expect the patient to have an electrolyte imbalance and fluid loss. So I have to resuscitate the patient. So I will immediately do a electrolytes, serum electrolytes. I will immediately do a serum electrolytes will be done by me. Serum electrolytes will be done. And what is the finding of serum electrolytes is going to be 100 times asked MCQ in PG entrance exam. The patient is vomiting. So what will come out on vomiting? I'm going to tell you what is happening in electrolyte imbalance. Patient is vomiting. He is going to vomit HCl. First, remember, he is going to vomit acid. So HCl is vomited. Therefore, patient first of all develops metabolic alkalosis. Metabolic alkalosis and hypochloremia. Hypochloremic metabolic alkalosis has started immediately. The patient starts developing vomiting for even 5 days, 6 days. He may develop hypochloremic metabolic alkalosis. So when there is a metabolic alkalosis, you naturally know what happens in the kidney, in the tubules. What happens, you know very well. So in the proximal convoluted tubules, collecting duct, distal convoluted tubules. So the moment you start vomiting like this, what should get excreted in the urine as a compensatory mechanism? As a compensatory mechanism for metabolic alkalosis, bicarbonate should be excreted into the nephrons and it should come out of the urine. Bicarbonate should come in the urine. Yes, it happens. Initially, in the first few days after vomiting, the patient starts excreting bicarbonate in the urine as a protective mechanism. So that is a very simple mechanism you would have read in physiology. Whenever bicarbonate is going, it will pick up along with them sodium also in the urine. So sodium is also excreted in the urine. So sodium and bicarbonate are getting excreted in the urine for as a compensatory mechanism for alkalosis. That is bicarbonate getting excreted. But what to do? Bicarbonate will not go alone. He always carries one another friend with him. That is sodium. Sodium is also excreted. Therefore, the patient develops hyponatremia. But it not lasts for long period. Our body has a natural immune system, a natural mechanism where it will try to stop the sodium. And instead of sodium, there will be a mechanism happening which is going to secrete potassium. What is that mechanism? That mechanism is renin-angiotensin system. Renin-angiotensin system. These are pure physiology. When you go back and read the physiology, as per renin-angiotensin system acts, and aldosterone and the various mechanisms now causes potassium loss. Potassium gets excreted instead of sodium. So therefore, patients may also get hypokalemia. But you know, very important electrolyte in your body is potassium. So potassium loss may cause cardiac failure. Therefore, our body immediately acts to replace potassium with some other positive ion. So what will be the other positive ion? Instead of potassium, there may be loss of calcium. Calcium is going in the urine. So therefore, there may be hypocalcemia. But at one point of time, calcium is also very important in our body. So calcium is also preserved. And who will go for along with the bicarbonate as a positive ion? So therefore, to the bicarbonate ion, the person who is going to get excreted now is going to be acid H+. H+ instead of Na+, instead of K+, instead of Ca2+, H+ is going to come out of the urine. And this becomes the phenomenon known as paradoxical acid, because in a metabolic alkalosis, acid should be conserved, but this guy, paradoxical renal aciduria happens. So you might understand this mechanism all very clearly when you go back and study the physiological functions of the renal tubules from your Hayden and Genong. All these are from that book. I cannot go in depth, but this is a basic outline what is happening there. The electrolyte imbalance seen as hyponatremic, hypokalemic, hypocalcemic, hypochloremic, metabolic alkalosis with a paradoxical aciduria is a final phenomenon of the patient. So when I do serum electrolytes, what I will get is I will get all these findings. So the moment I see the patient, I will immediately correct this electrolyte imbalance using what is the fluid of choice. So when we are doing finally an exam, the fluid of choice is going to make us pass or fail. If we make a mistake in this step, we are sent back to the preparation again. So what is the best fluid here for a case of GOO? Please remember, all of you will be thinking, since there is a potassium loss, I will give a ringer lactate. Ringer lactate, if you tell in our days, it is failed, confirm fail in the exam. So normal saline with a KCl supplement is the correct answer. Why I should not give a ringer lactate? Anybody know why I should not give a ringer lactate? So you should know what is ringer lactate going to do. So please remember, in ringer lactate, there is lactic acid. This directly goes to the liver. In the liver, lactic acid is metabolized and finally releases bicarbonate. Already the patient is in alkalosis. You know very well the patient already is in alkalosis. If I give ringer lactate, the lactic acid gets converted to bicarbonate in the liver and causes aggravating of alkalosis. Please remember, therefore, RL is absolutely contraindicated. Absolute contraindication is ringer lactate. So this is the first thing the examiner will be expecting you the moment you start your preparation, presentation. The examiner will be expecting you to know whether you have a knowledge of the basics of electrolyte imbalance, because this is a management which should be done by a MBBS graduate. So if you make mistake in this, then there is no use or no benefit of asking any further questions. So you just think, if you are an examiner also, you won't ask any question if you are making a big mistake in this. So the moment I see a patient, I will correct the electrolyte imbalance and I will put a wide bore Ryle's tube. Please remember, a patient should be immediately put a wide bore Ryle's tube. Why should I put a wide bore Ryle's tube? Because I want to know what is the problem, whether it is a duodenal ulcer or cancer. I want to know it by putting a wide bore Ryle's tube and giving a wash. Wash the stomach for 3-4 days. Please remember, wash the stomach for 3 to 4 days. You should wash the stomach. Then only I can do an endoscopy. You cannot just like that go and shift the patient to endoscopy. So therefore, another catch point to fail you in the exam is, so sir, what will you do now, doctor? The moment he tells you, you should tell fluid electrolyte correction. Okay, he would have been knowing, oh, this guy knows fluid electrolyte correction. Let us go to the next thing. So how will you diagnose? They will ask that question. You should tell, sir, I will put a wide bore Ryle's tube and give a complete wash for 3-4 days. Then only I will shift the patient for upper GI scopy. If you tell I will do upper GI endoscopy tomorrow itself, that's all, you are failed again. Upper GI endoscopy should be done after preparation of the stomach. Please remember, after preparation of the stomach only, you should do an upper GI endoscopy. Before that, if you do, you are failed and you cannot do the scopy successfully. Please remember, upper GI scopy after preparation is the answer. So upper GI endoscopy will explain and show you what is the finding inside. So in upper GI endoscopy, if I do, I can go inside and see if there is a cancer. I can take a biopsy. So if it is a cancer there causing GOO, I can take biopsy. 6 to 8 biopsy should be taken from the cancer. If there is a chronic duodenal ulcer, so if I do inside, there is a duodenal ulcer in the D1, first part of duodenum, there is a duodenal ulcer causing cicatrization. I should do one more biopsy. What is it? Very interesting question. So if I am doing an endoscopy, if I see a cancer, no doubt I will take biopsy from the cancer to confirm it is a cancer. I will do endoscopy and take biopsy. If there is a duodenal ulcer, will I take biopsy from the ulcer? Please remember, no biopsy from the ulcer. Then what should I do when I'm doing when I see there is a duodenal ulcer? What should I do? I should take biopsy from the stomach. From stomach. Why? Why should I do? I should take some tissue from the stomach and I should test for rapid urease test. So rapid urease test is a test to look for Helicobacter pylori. So H. pylori is positive in most of the duodenal ulcers. 90% of the duodenal ulcers will have H. pylori positive. So I want to confirm whether there is H. pylori positive or not. So if it is a peptic ulcer, definitely I should do H. pylori testing. If it is a cancer, yes, cancer also is caused by H. pylori, but not so important at this point of time. But if it is a duodenal ulcer, the management is going to be the treating of duodenal ulcer. So H. pylori testing is must. In cancer stomach, biopsy of the lesion is must. So now here comes the moment you start telling endoscopy, the examiner will ask you an interesting finding. In which are all the cases of cancer, please remember, in which are all the cases of cancer, upper GI scopy looks normal. Tell me, it looks normal. Upper GI scopy looks normal in number 1, Lynitis plastica, because it is a submucosal spread of tumor. So Lynitis plastica, if I do an endoscopy, it will look normal and the stomach will be non-distentable. I cannot, if I push the gas, I cannot inflate the stomach. Stomach non-distant. So upper GI scopy looks normal in Lynitis plastica. In lymphoma, in GIST, these are the tumors where the stomach looks normal because these are all not mucosal tumors. They are all tumors below the mucosa. So in these cases, the stomach looks normal. Therefore, upper GI scopy is normal in what are the cases? Lynitis plastica, lymphoma, GIST. So these 3 cases, therefore, we should depend on CECT abdomen. CECT abdomen is better for these cases, contrast enhanced CT abdomen. So when some old examiner comes for the exam, they will be expecting you to answer a question on barium meal. Barium meal will you do? The moment the examiner asks, will you do a barium meal? You should immediately tell, sir, barium meal is an old investigation which is now totally replaced with the help of endoscopy. So in the recent practice, I don't do barium meal. That's the best answer. In recent practice, we don't do barium meal at all to diagnose whether it is a cancer stomach or a peptic ulcer. This is totally gone. So it's totally gone. But there are some MCQs for this, for your exam, for barium meal. Barium meal showing hourglass deformity, where you get like this. This is hourglass deformity, GOO. Barium meal showing teapot deformity, like a teapot. Teapot deformity. Barium meal showing trifoliate deformity of duodenum. So like a trifoliate, like this. Like this, the duodenum is looking like this. Trifoliate deformity, where will you get? Where will you get a trifoliate deformity? A barium meal showing a simple line known as Hampton line. Hampton line in the stomach. Hampton line. Hampton line. And barium meal showing a sign of meniscus here, like a meniscus here. So there is a meniscus-like appearance, meniscus sign in the stomach. Okay, these are various, this is known as Karman meniscus sign, Karman meniscus sign. So you should know where you get this. Definitely the examiner is not going to ask you and not going to decide your rank based on this. These are some funny questions which are no more seen, no more done. Hourglass in a chronic gastric ulcer causing GOO. If there is a chronic gastric ulcer here, it can cause GOO. Teapot deformity due to chronic gastric ulcer with GOO, another gastric ulcer. Hourglass is due to gastric ulcer on the greater curvature. Teapot is due to a gastric ulcer on lesser curvature. So gastric ulcer is totally not seen nowadays. Trifoliate is due to deformed due to D1 ulcer. D1 ulcer causes trifoliate. Hampton line is due to what? Due to thin line. It is a thin line seen in benign ulcer. This is a Karman meniscus sign as a feature of malignancy, malignant ulcer in the stomach. So these are just for funny MCQs which are asked in PG entrance exams. You might not need in final year. You can just remember what are the barium meal findings. These are totally obsolete, not done nowadays. Not done nowadays. So you have to now move on to the next investigation. So if you have found on endoscopy it is a cancer, what is the investigation of choice to stage the cancer? If it is a cancer, I should now do the staging of the cancer. Please remember, I should now do the staging of the cancer. Staging of the cancer is CECT abdomen. CECT abdomen is one method. Another method which is not available in most of our medical colleges is EUS, endoscopic ultrasound. So what are the investigations to stage the cancer? So what is best, I will tell you later, but please remember what are the investigations. For staging the cancer, I will do EUS, I will do CT abdomen, I will do PET CT. PET CT. Or number 4, I will even do a staging diagnostic laparoscopy. Please remember, diagnostic laparoscopy is also an investigation of cancer stomach. So which is the best for each? So please remember, EUS is the investigation of choice for T staging and N staging of cancer stomach. Very interesting point. But since in our medical colleges we don't have EUS, we commonly used for T staging, N staging is CT abdomen. Best is EUS. But since we don't have EUS in our practice, we use CT abdomen. PET CT is the investigation of choice to look for METs. So what is the most common site of METs? Most common site of METs in cancer stomach is peritoneal METs are common. Peritoneal METs are very common. Therefore, the peritoneal METs, if you are not going to do PET CT, can be detected with the help of staging laparoscopy is most sensitive. Most sensitive for peritoneal METs is staging laparoscopy. So most surgeons nowadays, before doing a gastrectomy, they go for staging laparoscopy. So in your case, I'm asking you a very simple question, which is a postgraduate level question, but it is very simple and logical question. Your cases, so you have to now restrict yourself to your case. So what will you do as an investigation for your case means the answer ends with the CT abdomen only. I don't do EUS because in an obstructive growth, the EUS probe will not pass. So EUS is not done in your case. PET CT is not done in your case. Staging laparoscopy is not needed in your case. Why? Sir, why you are telling there is no need of PET CT or DLAP? Because anyhow, your case is a case of gastric outlet obstruction. Your case is a case of gastric outlet obstruction. I am going to do, if it is inoperable, I will do a palliative GJ. I will do a palliative GJ. Even if the cancer is inoperable, I will do a palliative GJ. Therefore, I don't need a staging laparoscopy or PET CT. So these two are a must. Staging laparoscopy and PET CT are must for proximal gastric cancers. Very important. Proximal gastric cancers, they are must. I hope you are understanding this concept. The concept is, distally there is a cancer causing obstruction. If I don't do something for that, the patient will die of vomiting. At least I will do a palliative GJ. When I'm going to do a palliative GJ by laparotomy, I will see whether there is peritoneal mets, liver mets, everything I can directly see. Then why should I go for a costly 20,000 rupees PET CT or a 60,000 rupees staging laparoscopy? They are not needed in such cases. So staging laparoscopy and PET CT are done only when you are not going to do any palliation. Example, it is in the proximal gastric cancer. If there are some MS postgraduates attending this case, there is a catch point for you guys at this point of time. I am an examiner now. I am a surgical gastroenterologist examiner. I am asking you, is it a must? Is it a must to do staging laparoscopy even in a patient with GOO? It is not must because I am going to do anyhow palliative GJ. I will tell you as a surgical gastroenterologist, I am telling you now, no, you must do staging laparoscopy. For a GOO case also, you should ask why, sir, please tell me why. The reason is nowadays nobody is doing palliative GJ. This is a GJ done for cancer stomach inoperable cases. Nowadays, what they are doing nowadays? Nowadays, we keep a stent through the growth like this. So nowadays, self-expanding metallic stent available for GOO. because this patient is going to live for 6 months to 1 year. Why should we go and do a surgery, a surgical complication, etc., etc.? Better keep a stent and come out. Is the latest concept. This is a recent concept. Which is best? Which is best? Now question is, which is best? SEMS is best or palliative GJ is best? So better than SEMS, surgical is best. Surgical is best. Surgical bypass is always the best if patient is fit. But by chance patient is unfit and you feel there are so much of meds, you can even go for a self-expanding metallic stent. Okay, so you will understand this when you go for the management. So these are the investigations you should do for a cancer stomach patients. So cancer stomach patient is now going to be treated by you. So cancer stomach. So cancer stomach, this is Mr. Ramu. Okay, this is Mr. Ramu. What you are going to do with the GOO? He is now in front of you with the GOO. So cancer stomach patient, Mr. Ramu, you have confirmed he is a case of cancer stomach with GOO. So I have completed the investigation and I have confirmed it's a distal gastric cancer, and I'm going to plan the treatment now for this guy. So I will complete the treatment in one line and I will explain about the things later. So the treatment for this guy is now subtotal gastrectomy. Please remember, this is the final answer the examiner will be expecting from you. Subtotal gastrectomy plus D2 lymphadenectomy. So please remember, an operable case. What I'm going to do? I'm going to do subtotal gastrectomy with a D2 lymphadenectomy like this. So this is a subtotal gastrectomy. The cancer is removed and this is the duodenum stump closed. Now I have also done D2 lymphadenectomy, which I am going to explain later, and followed by reconstruction of the luminal continuity. Reconstruction is commonly done by 3 methods are there. That is very important. You might be asked by the examiner to draw and show the reconstruction. This is the most commonly done reconstruction. What is this? So the most commonly done reconstruction is shown here. This is known as Bile 2. Please don't forget, I'm drawing you all the reconstructions. This is a picture showing you after subtotal gastrectomy, D2 lymphadenectomy, reconstruction with a Bile 2. In Bile 2, there is one anastomosis, that is gastrojejunal anastomosis, and the duodenum first part is cut, and this is the stump of D1. This is the stump of D1, duodenal stump. So the second question is, now I am going to do another reconstruction. This is the subtotal gastrectomy. After doing a subtotal gastrectomy, what is Bile? That is Bile 2 means that should be on Bile 1. No, that fellow did approximated the duodenum to the stomach. This is stomach, this is duodenum. He approximated gastroduodenal anastomosis, known as Bile 1. Nobody is doing this operation nowadays. Bile 1, nobody does this operation nowadays. So another operation, what is the other operation done? There are 3 operations of reconstructions. This is a subtotal gastrectomy done. This is the cut end of duodenal stump. You see, this is a DJ flexure. Let us assume this is a DJ flexure. I am not going to do GJ now. I am going to leave the jejunum. I cut the jejunum here. Please understand, this is jejunum. I am cutting the jejunum. I am cutting the jejunum here. This cut end of jejunum, I am bringing it to the stomach like this. I am now doing a GJ here with a cut end of jejunum. And now this is the remaining jejunum continuing. I will be now anastomosing this jejunum to jejunal anastomosis. So it looks like a letter Y. Can you see? This is looking like a letter Y. So there is a GJ, there is a JJ, there is a duodenal stump. So this is known as Ru and Y reconstruction. Ru N Y reconstruction. What is the disadvantage of Ru and Y? Can you tell me what is the disadvantage of Ru and Y? In Ru and Y, you can see there are 2 anastomoses. One is GJ, another is JJ. There are 2 anastomoses. There are 2 anastomoses. This limb which is going up is known as Ru limb. This is known as Ru limb. And because of this Ru limb, we can get herniation behind the Ru limb. Herniation can happen behind the Ru limb, known as Peterson hernia. Peterson hernia is a herniation behind the Ru limb, known as Peterson hernia can happen. So herniation behind the Ru limb is known as Peterson hernia. So many complications are there in Ru and Y. So you should be asking, sir, then why are you doing this operation? There are so many complications in Ru and Y. Then why are you doing this operation? One surgery is modified by other surgery, not for any demerits. There may be an important merit. There may be an important advantage. Can you guess what is advantage which is not which is not seen in Bilrath 1 and Bilrath 2? The advantage is very simple. Please remember what happens in Bilrath 2. This is bile, pancreatic juice entering into the lymph. That will enter into the stomach, and it will again, along with the food, will go down like this. So what happens therefore? Therefore, the food is entering and striking the stomach, causing a major complication, the clinical feature of bile reflux gastritis. Bile reflux gastritis is a complication of Bilrath 2 surgery. Very, very dangerous complication. Bile reflux gastritis is seen with Bilrath 2 cases. To prevent this bile reflux, what happens in Roux-en-Y? See the picture. Bile goes like this, bile goes like this, bile goes like this, bile will go like this. Even if it comes up, it will not come to stomach level. So there is no bile reflux gastritis. So no bile reflux. So each surgery has a merit and demerit. So Bilrath 2 will have bile reflux gastritis, whereas a Roux-en-Y reconstruction, RY reconstruction, Roux-en-Y reconstruction, there is no bile reflux. There is no bile reflux. But what is the problem of Roux-en-Y? Roux-en-Y can have two important complications. One is two anastomosis will be there. So two anastomosis, therefore increased chance of leak. And number two, Peterson hernia can happen. So these are the essential points you should know. After a subtotal gastrectomy, Mr. Ramu will undergo D2 lymphadenectomy and reconstruction by any one of these three methods. And if you ask me what I will do, I will always do only one method, that is Bilrath 2. So always only one method for all my surgeries. Though there may be multiple options, because I used to think in your lifetime, if you get trained with one procedure, whether it is a procedure or any future program or plan, if you concentrate on one important aspect, definitely you can master like anyone or master than anyone in that field. So that is the reason any surgery, I do only one method. I don't do multiple methods. I don't want to train in multiple ways. As a surgeon, I want to master the skill of one technique. And in my surgeries, I only do Bilrath 2, and I never see any of these complications. And I always do Bilrath 2 in my practice. Okay, so Bilrath 2 is commonly done not only by me. Most of the surgeons do Bilrath 2. In Western countries, most of them do Roux-en-Y. Nobody does Bilrath 1 nowadays. So Bilrath 1 is a gastroduodenal reconstruction. Nobody does it. So just leave it. Okay. Sir, you told something about D1, D2 lymphadenectomy. Let me tell you what is it. So D1, D2, D3 are the three types of lymphadenectomy surgeries which are explained excellently in Bile and Love. You should never ever think of any other book if you want to read about stomach. If you want to read stomach, you should first read Bile. Everything what I'm taking you is there in Bile. A few points may be out of syllabus, but please remember Bile is one of the Bible for surgery. Okay, it's one of the best for surgery. So this is a very important question on. So now we are going to the lymphadenectomy concept. So a cancer stomach first spreads to the nodes. Please remember that first point. If there is a cancer in the stomach, it will first spread to where? Nodes. So therefore we have three levels of node. Level 1 nodes. Level 1 nodes are the nodes within 3 centimeters from cancer. Please remember, within 3 centimeters from cancer, it is known as level 1. Let me tell you what are those nodes. So level 1 has station 1, station 2, station 3, station 4, station 5, station 6. So these are the first 6 stations of level 1, level 2, level 3, level 4, level. These are the stations node. Station is right cardiac node. You can see in 1, we have right cardiac node. 2, left cardiac node. 3, lesser curve node. 4, greater curve node. 5, suprapyloric node. Please remember it is suprapyloric node. 6, infrapyloric node. So these are the nodes belonging to level 1. So when I'm doing a cancer operation, I should remove all these nodes. Level 1 nodes, all these nodes should be removed by me while doing a gastrectomy. So this one is level 1. Level 2. Level 2 are the nodes in close relation to the blood vessels. I'll show you what are the blood vessels. I hope you know the blood vessel anatomy around the stomach. This is celiac artery. This is left gastric artery from celiac artery. This is splenic artery from celiac artery. This is common hepatic artery from celiac artery. These are the three major vessels. So now let me tell you what are level 2 nodes. Level 2 nodes, we have to know 7 is left gastric artery nodes. Along the left gastric artery, if you have nodes, it is 7. Along the common hepatic artery, if you have 8. 9 is a node in the celiac artery nodes. These are very important questions you should know for your exam because these are updated in 27th edition Bile. Okay. 10 is the node in the splenic hilum. 10 is splenic hilum nodes. 11 is nodes along the splenic artery. So this is 10, this is 11, splenic artery nodes. So what are the level 2 nodes? The nodes along the vessels. So what are the vessels? Number 1, left gastric artery node, common hepatic artery node, celiac node, splenic hilum node, splenic artery node are coming under level 2 nodes. So what is level 3 nodes? Level 3 are 12, 13, 14, 15, 16. I don't want you to remember everything. Therefore, I'm just telling only few 12 and 16. So 12 is a node, retrohepatic nodes. So hepatic nodes. Retrohepatic nodes means nodes along portal vein, hepatic bile duct, and along the hepatic artery. So the 12 is nodes along the major structures. 3 important structures, no, portal vein, hepatic artery, bile duct. Along that is known as 12. So 16 is para-aortic nodes. So what is this D1? Please remember D1 is removal of stations. 1 to 7 stations are removed. D2 lymphadenectomy is stations 1 to 12 stations are removed. D3 lymphadenectomy is removal of stations 1 to 16 stations are removed. So D1 lymphadenectomy, I should remove all the nodes. 1, 2, 3, 4, 5, 6, 7 nodes I should remove. D2 is 1 to 12. D3 is 1 to 16. The D3 lymphadenectomy is done only by this Japan guys. Japanese only do this surgery. The gold standard is D2. D2 is the gold standard lymphadenectomy. Therefore, for your PG entrance exams also, you will get what is D2 lymphadenectomy means. I will remove the nodes, right cardiac, left cardiac, lesser curvature, greater curvature, suprapyloric, infrapyloric, I will remove. And along that, I will remove the left gastric artery, also is known as D1. If I remove left gastric artery, common hepatic artery, celiac, splenic hilum, splenic artery, it is known as level 2. So level 3, level 2 includes 12 also. Level 3 is all the 3 are removed. So this is lymphadenectomy. So a case of lymphadenectomy includes removal of all these nodes will be removed in lymphadenectomy surgeries. So please don't forget these points, very essential for your exams. Okay, these are very essential points for your exams. D1, D2, D3 lymphadenectomy operations. Now, we have now managed a cancer stomach. So Mr. Ramu, coming to you, you did a surgery because I only wanted to restrict to this case. I'm not going to discuss unwanted questions out of this syllabus. So I will restrict myself to D1, D2 lymphadenectomy with the subtotal gastrectomy with the Billroth-2 reconstruction is the one you should tell for a cancer stomach cases coming to you. So if a case of chronic duodenal ulcer is kept for you, this is Mr. Somu coming to you with a chronic duodenal ulcer. So he is coming to you with a chronic duodenal ulcer with cicatrization. So what will you tell for this guy? What will you tell for this guy with a chronic duodenal ulcer with cicatrization causing GOO? So for understanding this, I request you to please understand the vagus nerve anatomy. Please remember, duodenal ulcer is because of the increased acid production by the vagus nerve. So therefore, you should know there are 2 vagus nerve. This is left vagus nerve, very thin nerve running anterior to the stomach. So left vagus nerve runs anteriorly. Please remember, left vagus nerve runs anteriorly. Right vagus nerve runs posteriorly. So this is right vagus nerve runs posteriorly. So left vagus runs anteriorly, right vagus runs posteriorly. So these are the two nerves which are going to supply the major parietal cells. So please remember, they are going to supply the parietal cells like this. So they supply the parietal cells which are going to produce acid producing parietal cells. The main thing I'm discussing this here because they are going to supply the acid producing parietal cells. So these are the two vagus nerve. So they end on the pylorus. What is the name of this nerve on ending on the pylorus? Looks like a crow's foot. Looks like a crow's foot, known as nerve of Laterjet. Known as nerve of Laterjet. So left vagus nerve runs anteriorly like this thin nerve. Right vagus nerve runs posteriorly like this and causes a supply. So both of them have nerve of Laterjet. So what are the other branches of left vagus nerve? Please remember, left vagus nerve has one interesting branch that is going to the liver, known as hepatic branch. Hepatic branch. It will go to the liver, known as hepatic branch. Right vagus nerve has another interesting branch, which is an image-based question for exam. This is a right vagus nerve giving a branch to the fundus. What is this branch known as? This is an image-based question asked in FMG exam and NEET PG exam. This is known as criminal nerve of Grassi. So posterior vagus nerve gives a branch to the fundus of stomach, known as criminal nerve of Grassi. Posterior vagus nerve also gives a branch to the celiac plexus, known as celiac branch. So these are the various branches of vagus nerve. You should know the branches of vagus nerve and what will happen if I do truncal vagotomy from the basics from Bailey and Love. So vagus nerve anatomy is this. So I am going to do, this is a case of chronic duodenal ulcer with a cicatrization here. So as I receive Mr. Somu, I will immediately plan for a surgery known as truncal vagotomy. I will cut the vagus nerve here and here. Cut the neck itself. I'm going to cut the neck of the vagus. So everything is gone beyond. So I will do a truncal vagotomy. So truncal vagotomy, if I do, please remember the function of nerve of Laterjet. What is the function of nerve of Laterjet? It is essential for pylorus relaxation. So therefore, if I do truncal vagotomy, the pylorus will go for narrowing. That is going for pylorospasm. They will go for pylorospasm. So the pylorus relaxation and pylorospasm will happen because of the compromise of this nerve. So therefore, if ever I do a truncal vagotomy, I should always do a drainage procedure like this. Gastrojejunostomy should be done. GJ is must. Because the food now needs to go through this way. The food now needs to go through this way, known as gastrojejunostomy is must. So in simple, in exam, if the examiner asks you, what are you going to do for a duodenal ulcer cicatrization? Just to tell, I will do truncal vagotomy with GJ. So this GJ was once upon a time given by a mnemonic known as PV ring. It is no more followed. Please remember, it is no more followed. What is PV ring? PV ring means the anastomosis, no, this anastomosis, the GJ. The GJ is done posterior wall of stomach, posterior, and it should be vertical like this. It's a vertical anastomosis. And this will pass behind the colon. This is the colon, no? They go behind the colon, known as retrocolic. I for isoperistaltic. And no loop means very short loop. This limb should be short. This limb is known as afferent limb. Afferent limb should be short. And GJ. So this concept is no more. If some examiner is coming and asking you what is PV ring concept, he has not done a case of GJ. Okay. So posterior vertical retrocolic isoperistaltic no loop GJ is no more. Just do a dependent GJ. That's what we do in practice. We do a GJ so that the foot will go down. That's all. We have to do a GJ. It should go down. So truncal vagotomy with the GJ is done. Is the gold standard treatment for a case of chronic duodenal ulcer with GOO. So from truncal vagotomy with GJ, the examiner can take you to various concepts. He can ask you what is the other surgery done for duodenal ulcer. He can ask you start to ask you about high selective vagotomy. What is high selective vagotomy? It is not done for GO. Please remember, not done for GO. It cannot be done for GO. He will ask you high selective vagotomy. You should tell him, sir, in high selective vagotomy, I don't do for GOO. In high selective vagotomy, I will only cut the gastric branches like this. Small gastric branches alone is cut. What is the problem of high selective vagotomy? More than 10% recurrence of duodenal ulcer. There is more than 10% recurrence of duodenal ulcer seen with high selective vagotomy. So high selective vagotomy, I will not do for this case. I will not do for this case. That is the point you should tell. More than 10% recurrence of duodenal ulcer is high selective vagotomy. Please remember this point. 10% recurrence of duodenal ulcer is seen in high selective vagotomy. Truncal vagotomy, the recurrence is around 1% recurrence of duodenal ulcer is seen. Okay. So now you should know what are the problems with the truncal vagotomy. What are the complications? So the complications of truncal vagotomy is under 3 headings. Please remember, complications of truncal vagotomy is under 3 headings. Number 1, due to cutting of all nerves, due to compromising the nerves. So what are the compromising we are doing now? Number 1, we cut the celiac branch is gone. Please remember, celiac branch of posterior vagus nerve is gone. Hepatic branch of anterior vagus is gone. Crow's foot is gone. So what all complications will happen? Celiac branch is gone means the motility is disturbed and patient may develop post-vagotomy diarrhea. Hepatic branch is gone. The bile flow is disturbed, so the patient can develop gallstones. Crow's foot is gone, so the patient will develop pylorospasm. These are due to cutting of the nerves. Cutting of the nerves. And because of the GJ, the patient may develop malabsorption. Please remember, the food hereafter, whatever I am going to eat is going to go in this way. So the patient will develop a malabsorption. What are all the malabsorptions will happen means very simple. You should know what are the things which are observed in the duodenum, because no more food is going to enter this area. They are directly going to go down. So the things which are observed in this place, like calcium, iron. So calcium deficiency, iron deficiency happens. Even B12 deficiency also happens in these cases. Malabsorption of iron deficiency anemia, osteoporosis, and B12 deficiency happens. Malabsorption happens following a GJ because of the bypassing of the duodenum. And most important favorite question for your examiners is going to be asked on another interesting syndrome known as dumping syndrome. For final MBBS students, this is a very important topic on dumping syndrome. Let me explain you what is dumping syndrome. Please understand what is dumping syndrome. I'm going to show you the picture of dumping. So this is the surgery done now. This is afferent limb. Please remember, this is afferent limb. This is efferent limb. So afferent limb, efferent limb. So whatever you are going to eat hereafter, for example, I am going to take 3 parota. Okay, 3 parota or chapati I am taking now. These 3 items will go where? They will actually, if it was done for me, it will slowly mix slowly and go bit by bit through this way. But for this guy, it is now going to go directly into the jejunum like this. So the moment you eat 3 parota or chapati or roti, they will immediately go into the jejunum. And these roti are hypertonic, so they absorb the fluid into the roti. So there will be a massive fluid shift within half an hour, within 30 minutes. There is massive fluid shift seen. There is massive fluid shift seen, resulting in hypovolemia. So there is within 30 minutes, there is a massive fluid shift. Patient develops hypovolemia. This is known as yearly dumping. Yearly dumping. So what will be the clinical feature of hypovolemia? The patient will be dehydrated. Dehydration, giddiness is seen. So these are the classical features of yearly dumping. Dehydration, giddiness will be seen in yearly dumping. So what will now this Barota will do? This Barota will release the sugar. The sugar will go and produce the insulin from the pancreas. So insulin is secreted in enormous amount that will go and neutralize the sugar, resulting in 1 to 3 hours, the patient develops postprandial reactive hypoglycemia develops. This is known as late dumping syndrome. So postprandial reactive hypoglycemia develops and the patient will complain of sweating, palpitation, tremors. Sweating, palpitation, tremors are seen in these cases. Sweating, palpitation, and tremors are seen in these patients. So within half an hour, there will be hypolimia. Within 1 to 3 hours, there will be reactive hypoglycemia due to dumping. All this are happening because of dumping of so much of food into the jejunum. How can I prevent this? Don't do dumping. Ask the patient to eat small, frequent meals. Ask him to eat small, frequent meals, low carbohydrate meals, high fatty foods, and ask him to eat dry food so that the food will move very slowly. Dry foods. So dry food, low carbohydrate, high fatty, and dry meals are the advised diet for these guys. So a patient is coming to you with the dumping syndrome, advise them small, frequent meals, low carbohydrate, high fatty, dry foods. And if they are not responding, advise them to take injection. Octreotide is a drug of choice for dumping syndrome. So drug of choice for dumping syndrome. So drug of choice for dumping syndrome is injection octreotide. So the question will be very simple. So the patients are very simple. The two cases coming to you are Mr. Ramu with a cancer stomach, Mr. Somu with a duodenal ulcer with a cicatrization. So Mr. Ramu is diagnosed because of the history of old age, malnourished, loss of weight, loss of appetite, cachectic, had an umbilicus deposit. He had mass in the epigastric region. So once Mr. Ramu is diagnosed as a cancer stomach, we evaluated him with the endoscopy. After fluid correction, we did an endoscopy, confirmed with the biopsy, did a CT scan, and confirmed it is an operable cancer. And we did a subtotal D2 gastrectomy with a Bile-2 reconstruction. Whereas on the other hand, Mr. Somu is a case of duodenal ulcer with cicatrization. I will do now. The patient will be diagnosed because of his periodicity of pain and pain relieved by eating and long history. So the patient had no mass on examination of the abdomen. The stomach is very much distended. So I planned him for a simplified surgery, that is truncal vagotomy with the GJ. Before going for truncal vagotomy with GJ, I did a proper endoscopy, evaluated him for electrolyte correction, and everything was rectified. And I did a truncal vagotomy with the GJ. So whenever I do GJ, the complication which can happen is dumping syndrome. It can happen in Bile-2 also. It can happen in truncal vagotomy with GJ also. So please remember, dumping is not characteristic of any one disease. It is seen in both the cases. So this is actually the case discussion is over. Let me show you some of the interesting things which we have in PowerPoint. Let me discuss, and I'll ask you some Viva questions from now onwards. So I'm Dr. Rajamahendran. I'm a surgical gastroenterologist from Viluppuram Medical College, Government Medical College, and I'm a director of our PG Coaching Institute. RRM Next is one of the leading institutes in Tamil Nadu. For NEET SS, it's a #1 institute all over the country for among the surgeons know very well. So these are the points we are discussing. Now tell me the Viva questions which are being asked. What are the causes of massive hematemesis? So a patient is coming to you with a massive hematemesis, means the vomiting is having more than 500 ml of blood. So massive hematemesis, the first two causes you should know is duodenal ulcer, #2 varices. So most common is duodenal ulcer. The duodenal ulcer, the posterior duodenal ulcer. Please remember, if there is an ulcer on the posterior wall, it will bleed from the gastroduodenal artery. So duodenal ulcer bleeding from GDA is the most common cause of hematemesis. Varices from esophageal varices in DCLD, decompensated cirrhotic liver disease patients will develop varices. So the first question, what is massive hematemesis? More than 500 ml per day. What is the relation of pain and food intake in cancer stomach? In cancer stomach, pain is unrelated to food. Please remember, in gastric, ulcer, duodenal, ulcer, cancer, stomach. In gastric ulcer, pain increased on eating. Duodenal ulcer, pain decreased on eating. Cancer stomach, no relation at all. There is no relation of pain and food. It will be there all the time. Okay. What are the causes of pain radiating to the back in GOO cases? Can you tell me? In a gastric outlet obstruction, a patient is telling, sir, I'm having pain in the epigastric region. It is radiating to the back. It means, #1, it can be a cancer stomach infiltrating pancreas, #1. What else? Or it can be a chronic pancreatitis. Please remember, they won't keep you an exam, but chronic pancreatitis patient causing GOO. 3, cancer pancreas causing GOO. 4, even a pseudocyst causing GOO. So pancreatic causes will cause pain radiating to the back. Cancer stomach, chronic pancreatitis, cancer pancreas, pseudocyst, all of these guys can cause pain radiating to the back. Okay, can cause pain radiating to the back, seen in all these cases. History-wise, to say peptic ulcer or cancer stomach, I told you what are the history to say it is a peptic ulcer or a cancer stomach. Please remember it. Clinical examination findings also I told you. So, one of the important questions, one clinical finding, very important to differentiate GOO is due to peptic ulcer disease or cancer stomach, where clinically you can say this is cancer stomach. Can you tell me the answer? So the answer is, so clinically I can say this is cancer stomach by looking for a mass. Mass plus GOO is cancer stomach. Basic question, you should never make a mistake in this. So when you're getting a case with GOO and you found out a epigastric mass moving with the respiration, diagnosis over. It is a cancer stomach. So this is Sister Mary Joseph nodule on a CT scan. This is Sister Mary Joseph nodule on inspection. So this is a left supraclavicular node known as triceus sign. So this is a bilateral ovarian deposit seen only in premenopausal women. So please remember, this is a finding seen only in premenopausal women, not in postmenopausal ladies. So it is because of the ovarian follicles which rupture, that area becomes raw, and in that raw area, the tumor spreads transcelomically, causing Krukenberg's tumor. So Krukenberg's is a finding of premenopausal woman. It is not an ovarian tumor, it is an ovarian deposit. Okay, deposit. So electrolyte imbalance, I told you, please don't forget there is paradoxical aciduria. The initial thing is hypochloremic alkalosis. So what is the must before referring a patient to UGA-scopy? I told you we have to prepare the patient completely. See, this is one of my patients referred for endoscopy. Without proper preparation, you can see when I'm going to do in this patient of GOO, when I'm trying to do endoscopy, we can see a poor preparation cases, there will be full of food particles, everything. But this case you can see is well-prepared case. You can see a cancer in the level of incisura angularis. You can see there is a cancer, there is a pylorus opening. So this is a patient with a GOO due to some peptic ulcer disease. Okay, this is a peptic ulcer disease. So this is a patient who had a good preparation of GOO. So there is no food particles remaining inside. This is a case of a pyloric ulcer. I will take biopsy and I will confirm it. So this is a clear-cut endoscopy showing you a cancer stomach. In a well-prepared stomach, you can see there is a cancer. I should take 6 to 8 biopsy from endoscopy. So this is a classical picture showing you I'm doing an endoscopic biopsy. So you can see I'm doing endoscopically. I'm taking 8 biopsy should be at least taken from the growth. So this is a biopsy showing you. So this is another thing, a patient showing you the so we are doing endoscopy and we are entering the pylorus. That's a pylorus, as you can see, very narrowed. I'm entering the pylorus. Just to show you the endoscopy, what is being done in endoscopy. So I'm now entering the first part of duodenum. You see, that's a pylorus. We are entering pyloric orifice. We have entered and we have gone inside. And you can see this is a J maneuver. After coming out of the duodenum, we see a J maneuver in which we turn the scopy. Go down, turn the scopy and see what is there in the fundus. You can see in a J maneuver, we see what is there in the proximal stomach. I don't know whether you are seeing the videos clearly or not, because in Zoom, usually the videos will not be so clear. So what else must be tested during endoscopy? So this is very important thing should be tested. This H. pylori organism should be tested, especially for a duodenal ulcer. This is a rapid urease test. You can see the slide will be yellow color. When I put the tissue, it becomes pink color. It is positive. Rapid urease test positive. Is there a role of barium meal? I told you not done nowadays. This is Karman meniscus sign seen in malignant ulcer. So this is Hampton line. I told you seen in benign ulcer in the stomach. So this is a typical picture showing you a hourglass deformity. You can see it looks like a hourglass deformity in a GOO of stomach. So this is a EUS endoscopic ultrasound is the gold standard investigation for T and N staging. But since this is not commonly available in our practice, most of the time the surgeons may not be asking you in detail about the GOO. But for exam, you can get it as a short note. EUS in stomach cancer. You can see, you can get a short note on this. There are 5 layers seen. 1, 2, 3, 4, 5 layers are seen on endoscopic ultrasound. You can see 5 layers. The first layer is looking white color. That is known as hyperechoic. Second layer will be looking black. That is known as hypoechoic. Third layer is hyperechoic. Fourth layer is black, hypoechoic. Fifth layer is hyperechoic. So question which is asked in NEET PG exam is, what is layer 2? What is layer 4? So 1 is, please remember, 1 is mucosa. 3 is submucosa. 5 is serosa. So mucosa, submucosa, serosa are looking white color, whereas black color is muscularis, 2 is muscularis mucosa, 4 is muscularis propria. So these are the 5 layers. So I can tell you what is the T staging by seeing where the cancer is infiltrating. Up to which place the cancer is infiltrating, I can tell what is the T staging of the cancer. So roll up EUS in practice, we don't have in our institute, but it is the gold standard investigation for T and M. This should be your answer. So latest NCCN guidelines for PET CT scan is PET CT is advised for all cancer stomach patients who are going to be operated. Okay, PET CT is essentially done for all cancer stomach patients. So latest guideline for diagnostic staging laparoscopy, please remember up to 30% of the patients undergoing staging laparoscopy has become metastasis because of the peritoneal mets. So the overall sensitivity of laparoscopy for detecting metastatic disease is greater than 90%. So therefore, staging laparoscopy is a must for all the cases who are going to be operated for cancer stomach. Okay, please don't forget this point. So TNM staging, if you want, you can remember. Sometime they may ask you in the exam TNM staging. So Borman's classification of gastric cancer, you should know the Borman's classification. Borman's classification, type 1 is polypoidal growth. Type 2 is ulcero-proliferative growth. Type 3 is ulcerative growth. 4 is linitis plastica. These are the 4 types of cancer stomach: polypoidal, ulcero-proliferative, ulcerative, and linitis plastica. So I told you about diffuse and intestinal cancers of Lawrence classification. These are just theory, you should remember. But please remember, diffuse gastric cancer is seen in young females. They are associated with E. cadherin mutation. Okay. So the margin clearance, if there is a cancer, how much clearance should I give proximally means, if this is a cancer, I should give 6 centimeter margin. Distally, I cut up to D1. So NCCN guideline says 4 centimeter is enough. Sabiston says 6 centimeter. So for your exam, you should remember as 6 centimeter. Okay. NCCN guidelines say at least 4 centimeter proximal. For a cancer, we should give marginal clearance. So I told you the levels of nodes. You can see the stations of node up to 16 we have from 1. 16 is para-aortic node. This is very clearly given in Bailey and Love. This is from Bailey and Love. So level 1 nodes, what are the nodes removed? Level 2 nodes, what are the nodes removed? Nodes along the vessels. Level 3 along the major distant structures. All those things are removed. And this is Billrath 1. These are the questions the examiner may ask you to draw in a clinical viva. So they'll ask you, come on, draw and show me the Billrath 1. So Billrath 1 is a gastroduodenal anastomosis. Billrath 2 is a gastrojejunal anastomosis, like this. So this is Billrath 2. So the examiner may ask you to draw and show you the images of the Billrath 1 and Billrath 2 operations. So this is a case of Roux-en-Y. This is Roux-Lymph. So this is a Roux-Lymph which is being used for anastomosing after esophageal jejunal. After a total gastrectomy, this picture is shown here. Okay, this is not subtotal. This is a total gastrectomy for a proximal gastric cancer. So you can see this is a video showing you surgery done by me for a subtotal gastrectomy for a GOO. You can see that is the cut end of duodenal stump. That is a pancreas. I have done a D2 subtotal gastrectomy. So I am removing the nodes. All the nodes are removed along the D1 level, D2 level. All the nodes are removed. And I am now going to cut the stomach cancer proximally 6 centimeter margin. So what I am holding in my hand is the cancer here. That's a cancer causing GOO. I am going to give 6 centimeter clearance and I am going to cut at that level and I'm going to do a Billrath 2 reconstruction in this case. So you can see I'm same patient. I'm cutting using a linear stapler. I'm used to cutting the growth. I'm cutting the growth and removing the distal part of the stomach. This is a subtotal gastrectomy being done. So you can see this, the staplers has made the surgeon's life so simple. The one which takes half an hour can be done in 3 minutes or 3 seconds. So this is a specimen of subtotal gastrectomy. This is what we are going to do, subtotal gastrectomy with the Billrath 2 reconstruction. So there are so many, these are the various cases of GO. I'm telling you, every year we operate at least some 20 cases of subtotal gastrectomy for GOO. It's a very common cancer in Tamil Nadu. So many cases we have operated, all are D2 subtotal gastrectomy for GOO cases only, all are GOOs. So see, so many GOO cases we have operated for cancer stomach. See, this same day we used to operate sometimes many cases. See, same day we have done a subtotal gastrectomy and another total gastrectomy. So much of common in cancer. Stomach is very common. These are essential for SS level. So peptic ulcer causing GOO. What is the latest update? So I told you peptic ulcer causing GOO. What is the old treatment done, which your examiner will be expecting is truncal vagotomy with GJ. This is what you have to tell in your exams. But there is a latest update I want you to remember. Now what they are doing is Sabiston 21st edition has clearly mentioned no need of even TVGJ because we have excellent drugs to heal the ulcer like pantoprazole has come now. Therefore, endoscopic dilatation of the with or without stenting and H. pylori eradication are the mainstay of treatment now. Please remember, very interesting point. Endoscopically, we can do dilatation of the chronic cicatrized ulcer and I can put a stent inside without doing a GJY open method. Though we are not doing in practice commonly, these are there in Sabiston 21st edition. So this can be done. Just have in your mind, I can do endoscopic treatment for chronic duodenal ulcer. The examiner asks you more. It is a latest update from Sabiston. So salient questions from truncal vagotomy and GJ. What is criminal nerve of Gracie? It is a branch of posterior vagus nerve. Nerve of lateral jet supplies the pylorus, causing pylorus relaxation. High selective vagotomy, only the gastric branches are cut. Types of drainage procedure is commonly done as GJ. I told you, commonly done drainage procedure only, I told you that is GJ. Another procedure is also there. I can cut to open the duodenum like pylorus like this, and I will close it like this. What is this? This is known as pyloroplasty. But you should not tell pyloroplasty for GOO cases. You should only tell GJ. Pyloroplasty can be done for a non-GOO case. So truncal vagotomy with the GJ or a truncal vagotomy with the pyloroplasty are the types of drainage procedures. So the afferent loop syndromes are not essential for final MBBS level, but I will tell you what is that. Afferent loop and efferent loop syndromes are nothing but these are the two limbs I told you. If this afferent limb gets obstructed, it is afferent loop syndrome. This is obstructed is known as afferent loop syndrome. If this is obstructed, it is known as efferent loop syndrome. But this is usually a PG level question. They won't ask you what is afferent and efferent loop syndrome, but UG level, they will definitely ask you what is dumping syndrome. And how to prevent dumping will be definitely asked. There are two dumpings, early and late. Early dumping happens within 30 minutes. Late dumping happens in 1 to 3 hours. It is due to hypoglycemia. Early dumping is due to hypovolemia. Prevention of dumping is by eating a dry, small, frequent meals, high carbohydrate, low fat diet. Sorry, low carbohydrate, high fat diet. So differential diagnosis, you should know the questions. At least the examiner sometimes may ask you about the other things. This is a case of congenital hypertrophic pyloric stenosis, usually seen in 4th week after birth. The baby presents with the circular muscle hypertrophy of the pylorus, so the baby may have non-bilious vomiting. We have to do the surgery. The shown is known as Ramstad's pyloromyotomy. Ramstad pyloromyotomy is done. So these are some of the questions from GOO. So this is a baby with a 2 bubble appearance having a bilious vomiting. This is known as duodenal atresia. They have a bilious vomiting. The treatment is duodenostomy. Such double bubble appearance is also seen in annular pancreas in the babies. So these are all pediatric causes of GOO, which will not be kept for your exam, just for theory. So this is triple bubble appearance of small bubble obstruction. Okay, it is not GOO, it is a triple bubble appearance of small bubble obstruction due to jejunal atresia. So this is a picture showing you an obstruction caused by a trichobazar. So this syndrome of long hair in the stomach extending to the ileum is known as Rapunzel syndrome. This is one of the recently done case by us. Very interesting case of Rapunzel syndrome we have operated recently, and it was even published in news channels and all. Shown, see, this girl presented, 14 years girl presented with such a huge mass of hair. You can see this is a stomach showing you full of hair. So we have done a Rapunzel syndrome surgery. You can say I'm now opening the stomach to remove the hair out. So the hair is now going to be removed. That is fully loaded with the hair. I'm trying to remove the hair out now. You can see that stomach takes the shape. The hair takes the shape of the stomach. See, it is not coming out with even a big incision in the stomach. I'm still further extending and I'm going to take it out fully. This is a typical case of Rapunzel syndrome, which was removed by us recently, some 1 year back during the, see, the hair is extending into the ileum. It is taken up from the duodenum. It has gone up to the ileum also. We are taking slowly. That is looking like a Rapunzel. I hope you know who is Rapunzel. Rapunzel is a cartoon character of the movie Tangled. She will have a long hair. So that syndrome is given as Rapunzel syndrome. You can see that is a Rapunzel syndrome with a long hair. See the size of the trichobazar. classical picture of trichobaza. See, it's removed in our hospital, and this is even published in many channels. So this is done by our team. So she is Rapunzel. You know her mostly from the movies of Tangled. So she's Rapunzel having a long hair. She'll have a long hair, and she will be living in she'll be locked by a witch in a small room like that. The movie goes on. It's a Rapunzel syndrome. So this is a syndrome of Wilkie's disease. I hope you know what is Wilkie's disease. It is a compression of third part of duodenum by SMA, superior mesenteric artery compresses, and the patient will have severe vomiting and typical GO symptoms. It is very common in malnourished people because of severe weight loss. There is a compression seen known as Wilkie's disease, also known as SMA syndrome. So please remember, these are the various causes of GOO. Now it's a time for any of your doubts. If you have any doubts, you can post. I may answer the doubts. Yes, if you have any doubts, please tell. If you have any doubts, you can always post. I'm watching for your queries. Yes,
Team Planet. Yeah, Team Planet. If there is any questions in the chat box, please share it here.
Yes, please tell me any questions.
Sir, we have not received any question yet from the delegates.
Okay, that's fine. If there is no doubt, I think we can end the session at this point of time. Any other doubts? If you have, also you can always follow me on my Telegram channel, T-Me Surgery Sixer. You can post your doubts here, or you can follow me in an Insta, the same Surgery Sixer, or in my Facebook. There is a group for final years, that is Surgery Sixer group. So Surgery Sixer group, if you type in Insta or Facebook or Telegram, you can get the details and you can post all your doubts there. Okay. Thank you for the opportunity, Dr. Praveen and Dr. Venkatesh, sir. Thank you so much. Any other doubts, if you have, you can post, or else we can end the session.
Thank you so much, sir. Thank you so much, sir. You have spent around 2 hours for us. It's we are very much privileged to have you here, sir. Over to Praveen for official vote of thanks.
Thank you. Thank you so much. Thank you.
Yeah. Sir, it's been a pleasure to host you, sir.
Thank you.
So I thank you on behalf of IMA in Tamil Nadu as well as SNO Tamil Nadu, and on behalf of all the delegates who have attended this session. It has been absolutely tremendous, and we wish to do many more webinars with you in the future, sir.
Sure, thank you so much. Thank you, Venkatesh.
Thank you. I thank Venkatesh sir for giving me the opportunity, as well as Abul Hasan sir and other office bearers of IMA in Tamil Nadu as well as SNO TM. Thank you very much, sir. We can conclude the session, sir.
Thank you. Thank you.
Thank you.
Thank you.
Thank you so much. Also, we are closing here for today. Good night.
Thank you.